I'm Tina Cheng, Chair of the Department of Pediatrics here at Cincinnati Children's Hospital, Chief Medical Officer, and Director of the Cincinnati Children's Research Foundation. And welcome to Cincinnati Children's Pediatric Grand Rounds and our series on Envisioning Our Future for Children. We are celebrating our 90th anniversary of the Cincinnati Children's Research Foundation, founded by William Cooper Proctor, and also our 100th anniversary as the founding of our Department of Pediatrics, founded by a gift from Helen Muhlenberg Emery. This is our 10th speaker in our series on envisioning our future for children to really guide us into the future. And just before we introduce our speaker today, our 11th speaker will be Antonio Novello, who will be speaking on March 8th at 9 o'clock in the morning. So put that on your calendar, March 8th. And she was, of course, our 14th Surgeon General. But today is our 10th speaker, and who best to talk about the future of children than Mark Wietecha, the CEO of the Children's Hospital Association. He recently announced his retirement, and I just wanted to take the opportunity to thank him for all that he has done for children. And I know he's not done. Really thank him for all he's done and what he will do in the future. I'm going to turn it over to Yema C. Jones, who will do the formal introductions.
Thank you, Dr. Chang. And again, welcome to this special combined Cincinnati Children's Pediatric Grand Rounds and Envisioning Our Future for Children. As a reminder, if you'd like to claim credit for today's session, you can do so texting today's unique 5-digit code. The code and phone number will be redisplayed at the end of the presentation if you don't quite catch it. If you're participating live and have not claimed credit previously, please claim credit using the QR code or the link that is being provided. This will also be shown again at the end. If you're watching this as part of our on-demand Pediatric Grand Round series, you can use the post-test link to both claim credit and provide your feedback on today's session. If you are joining us virtually, you are going to notice that we're on a different platform than we typically are for Grand Rounds. To ask a question, you can use the Q&A icon at the bottom of your Zoom screen. You can do so at any time during the presentation, and we encourage you to send your questions in as they come to you. We will answer as many as we can, but please be aware we might not get to all of them. If you're having any technical difficulties, you can also use the Q&A feature to contact our administrators. For those in the room, please use the standing mics as we typically do at the end of the presentation. Next week's Grand Rounds topic will be on childhood onset systemic lupus erythematosus, the neurohematologic paradigm. Our presenter is Dr. Ekemini Ogwu, who is one of our rheumatologic faculty here at Cincinnati Children's. And today's topic is health and healthcare perspectives. It's my pleasure to introduce our speaker for today, Mark Wietecha, who is the Chief Executive Officer of the Children's Hospital Association, representing over 200 children's hospitals in their role as leading national advocates for children's health in Washington, D.C. and across the country. Over the past decade, he has served at the forefront of critical policy advances for children, including 2 reauthorizations of the Children's Health Insurance Program, CHIP, and 2 reauthorizations of the Children's Hospital Graduate Medical Education Program, CHGME. That's for our residents and trainees here in the room. Mark served on point in the original passage of the ACE Kids Act, the first law passed by Congress focused on the care of children with severe lifelong health challenges. He sponsored the work enabling the first national CMMI demonstration project on care coordination, engaging thousands of families and children with medical complexity. During the recent pandemic, he led the advocacy for billions of dollars in federal CARES Act relief funding to children's hospitals and high Medicaid providers. Mark is nationally respected for his strategic work in academic medicine, where he has advised most of the leading US News and World Report medical centers and children's hospitals. Mark has been named among the nation's most influential consultants and as one of the 5 healthcare leaders to know. He is a regular presenter on the future of healthcare and cited in such media as the New York Times, Wall Street Journal, Politico, and National Public Radio. Mark's academic training includes a Master of Science in Pharmacology from The Ohio State University and a Master's of Business Administration from Indiana University. We are so thrilled and honored to have you here with us, Mark. I will pass and hand the mic over to you to present your presentation. Please join me in welcoming Mark.
All right. Hopefully that came up. And the toughest part of these presentations is fundamentally getting the presentation up and getting connected to all of you. So hopefully we have done that. So I want to thank you for the kind introduction. Okay, thank you for that kind introduction. All right, so I am not controlling my slides.
Mark, we can hear you loud and clear. Let's have you click into your PowerPoint there and try to hit your arrow keys just to transition it. There you go. Looks good. We can see it.
Thank you. You can get the guy up on the screen, but you can't get a lot more out of him sometimes. Thank you for that. So anyway, I wanted to thank all of you for the opportunity to join you. And we're going to go fairly quickly this morning. There's probably a lot of things that we could say, and the points I'm going to raise are potentially, long discussions each. But our goal was to kind of take a glimpse into the future a bit. We're going to look in the past to help us focus on that. And I do have no disclosures and no conflicts. So over my career, I found that there are a few pieces of the healthcare picture that are worth reflecting on and thinking about. They have proven to be relatively durable predictors of what's going on. And I think they're going to continue to be important. And I'll come back at the end and recap these, but I'd like to spend a few minutes each on what I call following the people. And that's really focusing in on the future demographics of kids. And I've got a little high level commentary there. We often get so financially oriented, we forget to count up the people we're taking care of. And so that is sounds intuitive, but it's amazing how often we lose the track. There's something I'd like to spend a few minutes on I call the demand technology paradox, and that really is the question of the impact of technology on the demand for healthcare services and how sometimes counterintuitive that has been. For those of you who like population health, I'd like to say a few words on this issue of investing in people, which is really kind of one of the big policy initiatives we always have going on, which is we invest in early childhood, we invest in young adults, we invest in lifelong well-being. And we're not actually being able to get to that, and I'd like to spend a few minutes on why not. A little bit about the business of healing, which is another area that is beset with all kinds of technology opportunities. And then at the end, a little bit about the roles, cost, and access to healers. And I'm going to use that word healers rather than providers, because I do think in some regard, we'll want to think more broadly about the continuum of people and technology that's involved in the healing process. So on the people issue, one of the great data sources is the Census Bureau forecasts. They're incredibly cheap if you don't figure out how much of your taxpayer dollars you're using to buy it. You can get on and find this stuff out. And they're utterly reliable over a long period of time for the whole country. I'm sure for River City, Cincinnati, these things are less reliable, but for the whole country, it's a pretty good indicator. So what we have over the coming decades, 70 million more people, and we will modestly climb up to a 400 million population. That's a very small compounded annual growth rate. The important thing in the growth are these next two categories. Really 40 million of this growth are over age 65 and only 5 million are under age 18. So if you've been keeping up with the news this week, it's been a lot of coverage on Japan and countries that are so-called aging quickly. For us politically, what this suggests is we have 40 million more people on Medicare and Social Security. And when you look at our federal budget, we're spending a lot of money on older people already and not enough on kids. The politics of this are going to be pretty much the same as they've been. If this was baseball, our 2020 box score is the adults outvote the kids 259 million to 0. and that doesn't improve as we go forward. So what this suggests for everybody on the screen, I usually say in the room, but I'm assuming many of us are on screens, is we have to rethink our advocacy and we have to rethink how we represent kids in a world that's increasingly dominated by adults. If you look at the dollar flow, and this is a period of dollar flow we're in right now, 2014 to 25, our investment on kids is relatively small compared to the adults. And as you've heard in the news, the interest rates go up and we spend more of the federal budget on that. So this is just a growth in federal budget over the period of time. You know, there's a tendency to take some doom and gloom out of this, that, you know, the adult aging population is going to vacuum all the dollars out of the budget and leave nothing for kids. But I would say there's also an opportunity here, having so many adults relying on a relatively smaller number of kids to change the politics of this. And we'll need to think about doing that purposefully, because the growth in this budget for people over 65 will be a very purposeful process. It'll be a very political process. So for those of us advocating for kids, we're going to need to be equally purposeful. But this is one of the first pieces to focus on. We're going to follow the kids. We do have a growth in children overall, and fundamentally, we have a challenge in keeping them funded on dollars. Now, normally I get an audience participation on this one, but since there's like I can't see anyone out there but my own little screen. This is an iron lung, this smiling little girl. This is at Los Angeles Children's Hospital about 70 years ago. And the reason for putting this up is I don't want you to feel that I'm anti-technology. Technology does cure and solve many things. It's really a brilliant piece of our field, particularly in pediatrics, where often advances are led in kids, as you know. So this piece of technology got obsoleted by another piece of technology called vaccinations. And it demonstrates that we actually can cure things. The reason for this slide is there's always this feeling that we're going to cure everything and that we're not going to have any demand for services. And I would say I'm kind of a pretty ardent children's hospital guy. It would be kind of miraculous and amazing, wouldn't it, if we could solve all the kids' problems and we really wouldn't need our high-tech children's hospitals. But there's a wrinkle to this, which is as technology has helped us solve problems and eliminate pieces of disease, it's also created more opportunities, and I'm going to suggest created more demand. Now, this smiling gentleman was a Hahnemann heart surgeon. This is 1957, so getting way back there. The reason for this slide is this was a period in time in which critical care is generally regarded as being created in the United States. The first NICUs, the first PICUs, the first adult ICUs. And that technology made possible heart surgery. This is a heart surgeon. As you know, in the 50s and 60s, the US adult and pediatric industries really kind of took off. So technology has kind of evolved. And I wanted to show you a chart, which you have to be a little wonky to love. But this is admissions per 1,000 population by age. So nothing amazing here. And obviously this is for all hospitals in the United States, since we've got the older 80+ group. This basic shape of the graph is a relative intensity of utilization. It simply says the older you get, the more hospital services you use. There's nothing that insightful about that. What's interesting is this graph, which is 40 years old, looks kind of the same in the middle today as it did then. What's happened since that 1950s and 60s period of time is we've created an additional bar of demand. And that's for people over 80 who was just a non-existent bar way back. But this is high technology. If you go over to Cincinnati's adult hospital, your colleagues, I think you're going to find most everybody in the intensive care unit are very senior in age, and we created this bar. And this was really the miracle of the NICU and what became possible through intensive care technology and the work that many of you do. These two bars are technology bars. I call them technology bars. They weren't possible 50 years ago. But when you look at the shape of these curves today, we use healthcare in the middle of the demographic spectrum. But the real consumers now are people that are in very vulnerable and frail conditions, either 1 pound human beings or 80 and 90-year-old, 100-year-old human beings on the other end. And so what has happened is we have evolved technology that has cured many problems. You could argue that many cancers have become more of a chronic disease than they have a lethal outcome. But at the same token, we have created more demand. And net technology creates demand because it makes opportunity possible. It makes life possible. It makes better lives possible. And that's something everyone aspires to, and it is the social culture we have. So this concept that we only have a growth in 5 million kids, but I'm going to suggest that technology is going to continue to increase the demand for healthcare, and it will particularly increase the demand for what I'm going to call high technology or high acuity, high complexity healthcare. That would be the adult academic medical centers and the pediatric academic medical centers, who really are the wheelhouses at the end of either end of the spectrum. So it would be lovely to eliminate all disease through technology, and maybe that will happen someday. But until we can kind of see some different outcomes, we're going to have more. We're going to have more demand, even with a modest growth in the population. So I'd like to shift gears to this is probably my most esoteric area, so apologize to you on that. Normally I can wave my arms around and stomp around the screen and point all this out, but I'm not an opponent of population health. I'm actually a huge fan. We're having trouble getting to it through the healthcare system. So you can address this, population well-being many ways. You can provide income security, you can provide overall safety and housing. The unique aspect of population health is to try to do that through the healthcare system. And I would like to comment a little bit on why that's been a problem. And I'm going to focus in on the ROI, or the return on investment, in a life course. And we're going to look at a couple of quick life courses. These are slightly wonky, but you might be entertained by them. So what this is a case study of a single person over their 0 to 65 lifespan, left to right on the bottom. What we have on the left side of the y-axis is their healthcare coverage. At what point in their life were they covered? How? So we've got Medicaid, military, commercial, and Medicare, just 4 buckets, kind of in bulk. So this individual person, which is kind of your case study, if you will, in the ideal population health individual, was born into a Boeing aircraft family. So Boeing aircraft, big employer in Seattle, usually over the years, a lot of Kaiser healthcare. So this person was born into commercial Kaiser product, stayed in it till they were 21, and themselves got hired by Boeing. So they rolled in and they finished their career there. And on the far right, they transitioned into Medicare at age 65. So the interesting thing about this slide, which is kind of the slide everyone assumes exists in population health to some degree, you've got basically 2 different insurance stops over a lifespan. So what this tells you is that this payer, if all the people that the payer had were like this, you would have a lot of incentive, wouldn't you, to invest in age 0 to 3, age 0 to 8, because you're going to have someone there at age 40, 50, 60 years old when all of those long-term healthcare benefits come to being. And we do a lot of pop health assuming this kind of a model, that people, payers, employers who pay, and governments who pay, whether it's Ohio Medicaid or the federal government paying for Medicare, that all these payers have this huge return on investment. And actually, if everyone looked like this, they really would. But the world, and so many of you on the phone here are like, or on the call are going to be like in that young zone. So if there's some faculty or some older people around, you relate to the next slide a little bit more. But this is a second case study. And this is what I'm going to suggest is a more typical person. It's actually a friend of mine. And she was born on the left in a Medicaid family. And her mother, when she was in high school, got a job, so turns green to commercial. She joins the military, Navy, at age 21. And so you can see that little blue bar. And after discharge, gets a job in the commercial sector and actually gets 2 or 3 different jobs over a period of about 10 years. So those are those little step greens in the middle. Starts her own business, goes on to Medicaid because it didn't go so well, and actually eventually throws in the towel, rejoins the workforce on the green, and has 2 or 3 more jobs before retiring into Medicare, age 65, just last year. So this individual has 13 health stops, what I'll call health stops along their life course. Average duration, about 5 years. Ranges from everything from your local Medicaid managed care organizations, that's what those red steps are, to the commercial employer sector, that's what the greens are, with a couple of other stops. One is in the military system and one is in Medicare. So the question here is, if this is a little bit more typical, which of these payers has a lot of incentive to invest in the future of this particular person? And I'm going to suggest this is one of our huge challenges with pop health or population health, are who has a long enough interest in your health and in your life to put material investment in you. And for kids, 0 to 3, 0 to 1, these, oh yes, I noticed some neonatal, prenatal stuff there, so I want to make sure I don't miss that. But we need a real keen focus on long-term to put in place, for example, a major investment in well child care for the Bright Futures guidelines. We need to think through where people have a highly attuned interest, because the benefits of these investments are way downstream. And by that time, you're on to another payer, another provider. And as you know, many of our insurance industry payers are for-profit companies, and they think in terms of return on investment very clearly. Now, I will end with a little pithy thing on this one, which is the long-term costs of better health for the country. So only in Washington can we actually come up with this. So I was, when we were working on ACE Kids, we were meeting with the Congressional Budget Office, and one of the analysts there was staring at me and wondering about the return on investment of well kids or healthier kids with medical lifelong complexity, and asked me the simple question, well, do they just live longer? And after I got over the initial shock of that, I said, well, yes, that is kind of what we do with adults as well. But the person provided me a paper from JAMA, I think it was 2013 or so. So CBO scored the tobacco legislation, which some of you may remember. It's been a ways back. And so my question is, the question they had is, did that legislation, which is designed to bring smoking rates down among people, did that lower the cost of care for the country? So the way Washington or the federal folks think about the cost of care is the costs that they pay. And so as it turns up on this particular legislation, the cost went up. And that's because more people lived to enter the Medicare program. And the longer you're in Medicare, you run up a federal tab. So I think this issue of who's paying and who's measuring become important. Technology, and I'd like to talk a little bit about healing to go through kind of a fourth bit of popcorn here. So as you all know, the news is full, and I'll date myself a little bit here. That's a bedside robot. I'm sure they're a lot cooler than that now, but that we would automate and Amazon would bring us everything, drop our Z packs off, by finding us digitally, and we'd have AI kind of driving all of this artificial intelligence. And if you needed to talk to a human, you can get a handheld in place. So the healthcare industry, and particularly many of our medical centers, kind of get dominated by this technology paradigm, which is we need to invest all our dollars here. We need to digitize everything. We need to be virtualized, and we need to kind of get ourselves into a mode where we are running just a giant telehealth operation. And I would say this, there are truths in everything I just said. But I wanted to share with you that I think for our industry and for many of our adult counterparts in academic medicine, if we stay on this slide alone, we will miss the entire bus. And so I'd like to spend a few minutes on what that bus looks like. And this is an important enabler of it, but it's not a replacement. So this is one of these kind of economic slides. What you have here, left to right, are the entire pediatric population stratified on the 3M clinical index. So what we got on the far left are kids with low health challenges, healthy kids. Far right, many health challenges. This would be your kind of medically complex population. And there's two different graphs on this slide. The one trending up to the right is our pediatric bed occupancy of our big 50 children's hospitals. And as you'd expect, the occupancy is very high with kids with lots of conditions. So, half our inpatient census in the United States are medically complex kids or children with medical complexity. So you'd expect that. Healthier kids aren't really much in our beds. The other slide, the other line is just the percentage of kids. So the majority of them, that's trending up to the left, are healthy or healthier, and a small number trending down to the right are high complexity. So nothing magic about the slide. It says sick kids are in our beds and healthy kids aren't, and the majority of kids are not medically complex. What's interesting is the systems for healing these kids. So what we have over here on the left then are the healthier pediatric population. They're mobile, they're episodic, they are very much people who can be cared for in what I'm going to call a more transactional basis. And much of the technology we saw in the prior slide, particularly what Amazon is investing in, what the private equity space is investing in, is built on this episodic transactional care of people who fundamentally are healthier or more well. And that is a big investment focus of the industry. And it is an important focus because this is a big chunk of our ambulatory business. And we even have medically complex folks, right, who benefit from a lot of this transaction. But it is not the whole care model, because when we watch this blue line, the question we would have is, well, who are in our beds? And these are chronic, complex human beings and their families. They may be chronic complex for their entire life. They are growing in number by 2 to 3 times the overall population rate. And they are folks who are not going to benefit solely by having an Amazon drone drop off their med packs standing outside. They need more than that. And these are two different healing systems. And I'm going to suggest we need to think about them very distinctly. So the episodic transactional care is enabled by technology. We can even automate big parts of it through bots and other kinds of things that come to your handhelds and remind you of things and engage you in care. But if you're on the right-hand side for pieces of your life, you fundamentally are going to need a relational healing model. We heal in relationship. And we are fundamentally health systems, pediatric health systems, that if we don't have humans seeing you as a patient or seeing you as a family and feel a sense of belonging, connection, familiarity, we don't have the same healing system. It's not all an army of moving robots, although those come in handy sometimes and they have a role. So we're going to be in a more complex ecosystem of healing, but this piece of it is our unique wheelhouse. This relational connection to the sickest children in the country is just not available anyplace else, available through our hospitals and through the work all of you, many of you are training to do. And I will give you a little, actually, I'm going to, I don't see the slide I want. It'll probably appear when I want it later. I'm going to come back to this and make a reference point at it. But I want us to keep this in mind. And I also am going to suggest for all of you who are the healers, we probably, we can't heal kids and families if we're unwell ourselves as a community. And we have had more distress, more stress cracks, more loss, if you will, of pediatric staff joy over this pandemic period. We took a lot of damage in that from a emotional and a cultural standpoint. And we will have to continue to stay on the path of this. I know this is a big effort at Cincinnati Children's and in all our hospitals. And it's not purely, I'm going to suggest, around, retaining staff and staff costs and those types of things. I think it relates to the ability of well thriving people to heal people in need. And we need to feel that ourselves. I also think we have a challenge in making our high reliability culture, Cincinnati's a leader in this, sustainable, because the jobs are not the jobs they were when we look back, 20, 30 years ago. I'm going to tell you a quick story here. I think I have a couple minutes on the clock before we'll get the hook. I had an opportunity to go into the Pentagon to make a presentation to the Joint Chiefs, and they take care of a pretty big block of kids through the TRICARE program, which is the active military duty insurance program. They've got 1 million or 2 million kids in that program at any given time, and about 120,000 of them are medically complex. And so these are service members who will self-select and try to get near bases that have a children's hospital nearby, like Jacksonville, San Diego, Philadelphia, that kind of thing. Anyway, I thought I'd impress them with this high reliability culture thing, because for those of you who've heard this presentation, the analogs that are referred to, or the metaphors, are often aircraft carrier, flight deck operations, or nuclear submarine operations, where high levels of precision are required. The margin of error are very small. So it's a high reliability, high accountability environment. So you get the picture. So I go through this. And after the presentation, an older, retired general kind of saunters up and goes, "That's incredible what you've said." Goes, "So the children's hospitals, like your PICU units and that, these are really high reliability environments." I said, "Well, not exactly the same, but yes, that's how we are trying to work with those." And he looked up and says, "Well, how long do you leave people in these environments?" And it took me a minute to understand what he was saying. You don't like leave people there, that's their career work. And his comment was, in our HROs, we don't leave anybody in those jobs more than a year or two. People time out, fighter pilots time out. We get people off those aircraft carrier decks. It's just too stressful and too sustained and too impactful. And so I think there's something there. It's just something we used as a colorful analog for HRO work in our hospitals. But it is getting to be harder work, isn't it? And we need to think about how to make that sustainable for the healers and the people working in those environments. I'll close on my fifth piece, which really has just to do with our need to knit together more of a continuum of care. And we have a couple of challenges. First, our traditional care models in the children's hospital world are on the right-hand side of this. Pediatric subspecialists, specialists, children's hospitals, specialized nursing, specialized pharmacists. The challenges we have in that one, these are not inexpensive. And number two, availability is relatively more limited. We have an exodus from smaller community pediatric services, and we have a growth in complex patients. So as a result, access into our pediatric care systems is getting more challenged. And on the left side of this continuum, we've got the opportunity to figure out how we get families, individuals, certainly community health workers, more involved with the equation. And it's a cost and it's an access issue. I would say I wouldn't worry for those of you who are trainees on the right-hand side of this equation, because this is a slide I was looking for a bit earlier. It does speak a little bit to complexity. What you have here are all the 2,000 hospitals caring for 30 or more admissions per year. And as we move along left to right, severity of illness in those admissions goes up dramatically. And what you have on the green line is the percentage of hospitals that fundamentally are taking care of the sickest kids. And what the way to read that is how we have 2,000 hospitals taking care of 30 or more admissions. We only have 50 in the entire country who take care of the far right spectrum. There's just 50 hospitals. They're not in all 50 states, as you know. I mean, the state of Ohio alone has 4 or 5 of these facilities. But what this does speak to is we will always have a huge, important role for the big tertiary children's hospitals. And I think we shouldn't worry about the demand there. The question is, how do we get accessibility into the rest of pediatrics? And that will require that we have some role changes in that continuum that I showed you. And I'll end on one of my favorite slides and how we're going to get through what I call the challenge of the guilds. So we are built in specialized blocks of people trained for specialized pieces with their own economics, their own associations, their own politics, their own work scope, and importantly, in some cases, their own legislative roles, which is who gets to get paid to go where for what. And getting through that will be, I think, our principal challenge for changing our healing model and our healing community. But we need to get on that continuum, because that left side of it, where lower cost, more accessible healers, that's where the growth really is happening out in the community. So I will wrap up. I think things for you to think about: keep the number of kids and adults both in mind. Let's assume we'll have a lot of magic technology, but it's not going to eliminate demand. It's going to create new and different kinds of demands. We have to solve this life course thriving if we want population health more properly, especially for young children. We need to solve this problem of who invests in kids. I do want us to think about the business of healing as a human business, as a people relational field, not purely a set of armies that are roaming around on wheels. And we'll have to rethink that continuum of care. And that will get rethought whether we want it to or not, because Walmart and many other people are creating workforce on the left side of the continuum. So I think I will wrap up on that. I do want to thank you for everything you do at Cincinnati. You are among our leaders in the world. You work in one of the world's very best, most important children's hospitals, and what you do and what you're becoming in your careers is important, not just to Ohio and the United States, but to everybody who watches and follows your lead. So I will stop with that, and thank you for your attention to my zany slides and my inept ability to get my slides moving, but I think we got through it.
Thank you, Mark. Yes, can you hear me okay?
I can hear you. Oh, wonderful. I see a few humans. Either that or
yes,
it's
right
just a, oh, great. I'm really happy to see you.
So again, for those in the room, thank you for all the points for us to think about and mull over. We definitely want this to be a two-way conversation. So thank you for allowing the ample time for the question and answer section. Please use the mics if you want to ask a question here, and online you can use the Q&A function. I'm going to get us started because in this series, we do try to ask our big thinkers and the folks we've had at the Envisioning Our Future for Children similar questions, just so that we can kind of follow along. And so I'm going to start with, if we asked you to predict the future, what is the most impactful change or innovation in science, healthcare, or health systems delivery that you think will transform how we operate in the next 1 to 2 decades? I think lots to pick from your presentation, but if you had to kind of hone in on 1 or 2.
I think our understanding of genetics and our understanding of the developmental pathways or lack of understanding in developing kids is going to be really an important piece of this equation. And it will, our knowledge there will advance in logarithmic time, as technology tends to do, not in arithmetic time. So I think the opportunity for us to understand more and understand how to intervene, I use that word kind of purposefully on genetics because there is so much opportunity to not do things well or to do things that create problems or have ethical problems. But I think that the genetics and our ability to understand the epigenetic expression, for example, of behavioral health, things like this, are really just packed with opportunities for us to change how things could be.
Thank you. And if you were to think about which kind of collaborations could facilitate progress in sort of the scientific and even the healthcare delivery systems, and in the innovation that you mentioned, are there any particular things that we as an institution can be thinking about as far as where to focus our collaborations?
Somewhere along the line, we will need to think about how our science, technology can interface and be more effective as an enabler of social policy. We have, for example, we know the value of well-visit care in kids, 0 to 1, 0 to 3. The Bright Futures work is, I think, quite definitive there. And this has been a body of work that's also recognized by HRSA here in DC. So that's a piece of our healthcare. We'll have to find a way to get that embedded in social policy in a more fundamental way. So we have a poor compliance with well visits. My data is less than half of them are actually executed in the United States. And among poorer populations, economically poorer populations, the numbers are worse. So can we take and automate well visits? Can we do things to enable us through our social policy to pay for and reach for things? And I do think these are where we can take the technology and the medicine that we know and sort through how we get it more profoundly connected to social policy, which oftentimes just deals with money. They just deal with finances. And so we can have a gap in the middle where we have technology to accomplish our bigger aims for pediatrics, but we can't get into policy, or do we develop policy that we don't really have any technology for, or fundamentally doesn't have the kind of impact we want. So, being a policy kind of wonky person, I like that interface between the research and the technology of our kids' hospitals, and ultimately the social policy and the developmental futures, the future thriving of kids, and particularly kids in inequitable and inaccessible locations for all kinds of reasons.
Transitioning, we have quite a number of questions from the virtual audience. The first question from Laura Nanista, she asks, transition to adulthood is a problem for children with special healthcare needs. Who provides the chronic relational care once they age out of the pediatric hospitals?
I love that question. What the question, it doesn't just suggest, it illustrates that our definition of kids is got to change, because there is no place generally for people to land whose medical record is a telephone book and who's been cared for by very exquisitely experienced subspecialists for their life. So they have nowhere to transition to. So one prediction I would make is, and this has been going on for a while, 100 years ago, the average kids in our hospitals were like teenagers. And then in the last 30 years, they've become single digit age. And a lot of that is technology, right? We talked about that. So now we have a bimodal future. We're going to continue to have very young people, but we're going to have to take care of people as they get older into their 20s and 30s and beyond. I don't see the adult world attuning to that. And part of the reason is, you remember that population curve, that first page? We have 40 million more Medicare beneficiaries. Each of them uses 3 times more services than a kid. So think of that as 120 million children of demand. And that's going to fall onto the internal medicine family practice community pretty squarely. So I don't think you're going to see the adult, I shouldn't call them adult specialists. They're the specialists who are trained to take care of principally adults. I don't think you're going to see them really tuning in on these medically complex children who become medically complex adults and have a chronology that fundamentally is a continuum of their life. I think that's going to fall to our hospitals. We have hospitals now, I want to say, not sure about Cincinnati. Boston, about 8% of the patient population is over 18 and are like cardiac alumni, cancer alumni, kids. So I think the transition we've talked about, I think now more as a continuum, and how we're going to build some of that continuum kind of hubbed around our specialists and subspecialists. And it may even produce some new kind of career paths, because a 30-year-old congenital heart person who also survived, let's say, some additional complexity, is going to be a very different, right, patient than a 5-year-old with the same problems. But I think your question is a brilliant question, and it's one that we'll have to think through from a program, caregiver, operational, who pays for those folks, because the Medicaid program pays for kids, and then you fundamentally could have to transition out. So I like the question. I think that answers us.
Yeah, Cincinnati, we certainly are in this similar boat as Boston, and trying to, I think, work through this and figure out how we care for these transitioning children. Go ahead, Scott.
Hi, Mark. Scott Callahan. I'm the medical director for the Complex Care Outpatient Center here. How do you make the policy discussion that your ROI is actually already a single payer healthcare system, right? Like, the Medicaid population is already paid for by the taxpayers of the United States. The military TRICARE is supported by the taxpayers of the United States. If you're a hospital medical system who is self-insured, you're selling a product that's purchased by taxpayers of the United States, and your employees are also taxpayers. And then when you transition to an adult, you are supported by the Medicare program, which is supported by taxpayers of the United States, so that you can leverage those services seamlessly to provide, the social impact that you've talked about, and to better leverage making sure that the adult care system can adequately support the technology-dependent individuals who be transitioning to those adult care providers.
Well, I think you put your finger on one of the great debates of probably our remaining, extant careers. We're only commercial insurance removed from public healthcare, right? Paying everything, as you pointed out. The issue is the programs and the actual caregivers are discontinuous. I think of them as islands of information and health risk and health interest. And what we have is an archipelago of these islands in the United States, not a big island. I think there could be opportunities to sort through whether or not you could create a voluntary or a test case, single payer, for a population of maybe more complex humans. That would be one thing to think about. We could take the ACE Kids Act and make that a Medicare-like benefit. In other words, lasts for your life, no matter what state you go to. But we'd have to think about some things like that to begin the process that you're talking about. The challenge we have is the politics. Each of these buckets you named has a completely different constituency, right? You've got the Medicare advocates. These are the voting seniors. And this is a program that periodically gets rattled around. It is right now in this whole debt ceiling dialogue here in DC. As, oh, that program Medicare might go bankrupt and we have to cut it back. And so it stirs all the seniors up, and there are many people, and they all vote. They're very powerful politically. And then the Medicaid group is a completely different group, like state-based young people, 40 million kids in Medicaid and CHIP. So we're, and all of you are principal advocates, nothing to do with Medicare. And you've got the military, which just operates on their own, as you know. And everybody who leaves TRICARE has VA benefits, but that's a different bucket. And then the commercial people like Amazon, eBay, you pick your choice. The new chip companies come into Ohio to make chips. You know, they're interested in workforce and being competitive. So I think we have a lot of political barriers to this, but I like what you've said, and you're right. If we just take the commercial insurance piece of it and think about how that could be different, you have the public paying for everything. It's just that it's broken up by your age, by your wealth status, by the state you live in. And until we can get through more of those, I think we stay in our kind of archipelago system.
Mark, I was struck by that story you told about the general and the HROs, and we have a couple of questions here along those lines from Andrew Cox and Don Niebrig. So when you describe focusing on relational healing while living in a system like ours that seeks to be an HRO, what does that look like? And how can we incorporate a better understanding of how to circulate providers from these intense roles that still utilize their expertise? What does that look like to actually be safer?
Well, you know, I think one thing it looks like is we try to grasp some of this technology to take away the time we have to have our healers spending on screens and documenting, so they can have more in-person, nose-to-nose time with their patients and families. And I do think that's a promise that is very real. The idea that we can use these chat bots, I just heard a presentation from the CEO at Stanford as the adult side about them trying to figure out ways to capture all of the verbiage in the operating room and have that stuff be translated automatically and then read by AI, so that we have less time creating notes, less time in the EMR, less time kind of chronicling everything. And you all know this painfully well. We have a lot of technology that, as a general rule, probably hurts our well-being right now, especially the EMR, probably the #1 attributed burnout vehicle of all time. But I would say that we're at the point in technology where there's more. So one thing it looks like is we use technology to reduce the amount of time we spend not with people. And for I think the immediate future, that's highly possible. The other is, I think we have to think through our care teams on that continuum. And this has been a work in process, so nothing new here. But we've got to use, I think, community health workers. You can be seen in the healing process. It doesn't have to be just the pediatrician or just the nurse. It can be a highly trained person on the team. I think this issue of feeling that you're connected to your healing process is a people person, but it can be other people too. And we have to think through how we're going to expand our teams and have more people involved in it.
If you were to help us think through what are the top 3 health needs of children and families moving forward, what would you say those are?
Well, I think more support in prenatal and 0 to 1 and 0 to 3. So I think we need to support young families and often single parents. And this idea that this just comes naturally isn't there. I think that's probably be close to my #1 need. #2, We have almost no real financial support for mental, behavioral, emotional health, particularly for adolescents. Got a lot of physical physical health budget, but mental health budget is terrible. And I do think number three, we're going to need to support the pediatric safety net in the United States. We have not enough pediatricians, not enough smaller community pediatric hospitals. And we're going to need to, I think, sort through getting more dollars into the reimbursement, Medicaid reimbursement for the hospitals, and certainly more training dollars into the CHGME and then pediatric training tracks. Because if we don't have providers, we don't have a safety net, there's not a lot we're going to do for kids from the health side of it. So those are the three I'd go for.
Great. Steve Musing, thanks you for your leadership for all the children's hospitals. And, you've seen the children's hospitals work more collaboratively on safety and quality. What do you think we need to do in the next 10 years to improve even faster?
For a minute there, I thought you were going to ask Steve Musing that question.
I'm sure he has been.
But I guess he's asking me. I think the safety movement is one of the most important and transformative things our industry has ever taken on. And I would thank Steve and all of you at Cincinnati. You have been like leaders in this in a huge way. What I would look for in this is sustainability over the next 10 years. The workload, the data reporting loads, those kind of things, we need to think how to streamline those and how to use what we've learned in 10 years and the 80-20 rule as much as we can to say, perfection is, I think, an important goal, but it also is one that is rarely a sustainable workload. And as we get to other expressions of quality, in addition to safety, we'll have to make room for that somewhere in the professional life of our caregivers and healers, because it is, I think, that work to lift it and get it moving was a big lift. And so how do we transition over the next 10 years and free time up for other things and not materially sacrifice the past that our current learning? And I think there's a lot that we can do there. So I'm really happy to hear the question.
And there are many more in the chat that we will not be able to get to. You definitely stimulated lots of conversation, but I will close out with this question. If you can tell us, what do you think is the unique contribution that here we can do at Cincinnati Children's to make scientific and healthcare delivery innovations in the future?
Our hospitals are principally places where expertise gathers. We think about our innovation, we think about research, we collect, we gather, and we kind of correlate brilliant people and brilliant ideas. I think that will continue to be a principal role of our more famous hospitals. That's all of you who have the reputation and market position and resources. I'm sure you don't feel you have everything you need, for sure. But compared to the 200 hospitals in the United States, compared to the fact there's only handfuls of other Cincinnati Children's in other countries, not even handfuls, maybe a handful. The biggest contribution is how do you have an environment where you continue to attract, bring together, and integrate people and not kind of get too thinned out, if you will. And that would include the in-person aspects of this. I think this is a personal connection. So that would be, kind of my simple-minded piece. I'd continue to be the gatherer of expertise and be creative and kind of bold about even programs that aren't that well funded or not funded at all right now. But what really does the future feel like? And to try to get as many people together as you can in those zones. Easier said than done, but I think it's pretty essential.
Thank you again, Mark, for a really interesting and stimulating hour. Lots to think about and help us as we move forward in the next century of Cincinnati Children's. Again, please give us your feedback on this grand rounds. We thank you for making the virtual visit to Cincinnati. Thank you again, Mark.
Thank you all. Have great days. Take care.